Hi everyone, I'm Dr. Perel and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. We're going to be talking about rheumatology today. Rheumatology is the medicine involved with joints. And we think about things like arthritis and every other kind of joint and musculoskeletal process. So I have a wonderful guest here, Dr. Daniel DeMizio. He's the chairman of rheumatology at Richmond University Medical Center. I shouldn't stumble on that word since I'm also at Richmond University Medical Center. And we're going to talk about rheumatological issues, and it's more common than you think. Arthritis is a very common disorder. There are different types of arthritides or kinds of arthritis. And we're going to really jump right in with an expert to help us understand arthritis and what we could do, and is there anything we could do about it? So welcome to the show.
Thank you for having me.
Thank you. So tell us, what is a rheumatologist and how does someone become a rheumatologist?
Yeah, so rheumatology is a very interesting field. It's often misunderstood and misrepresented, and I think that applies both to physicians and to patients because I think it's not well understood, I think. And kind of put simply, rheumatology is a field of medicine that deals with the treatment and the management of conditions known as rheumatic conditions. And these are conditions that fall under two major subgroups: musculoskeletal medicine, like arthritis, osteoarthritis, bursitis, tendonitis, sports injuries. And then for me, the more interesting diseases like the systemic autoimmune and autoinflammatory conditions like lupus and psoriatic arthritis. And in order to become a rheumatologist, it requires a lot of time, a lot of training, like all physicians. 4 years of undergraduate education, then 4 years of medical school. Then there's typically 3 years of either an internal medicine residency or a pediatric residency. And then a kind of subspecialty training, 2 or 3 years in rheumatology to become a rheumatologist.
Was there something about rheumatology specifically that drew you to it? You mentioned part of it, and I'll say, even from my own personal experience, being a neurologist, I see people of many ages. Again, I don't see young children, but I do see children all the way up to senior citizens, obviously. And is there something about rheumatology that drew you in?
So my decision to ultimately become a rheumatologist actually was more of a process of elimination. When I was in medical school, it'll probably come across as we're talking, but I'm a very excitable person. I get excited about all facets of medicine, to be honest. And when I was doing my internal medicine rotation, when I was doing cardiology, I fell in love with the heart and I wanted to be a cardiologist. And then when I was doing my gastroenterology rotation, my GI rotation, I wanted to be a GI doctor. When I was doing critical care, everything I was doing, I kind of fell in love with. And then I did a rotation in rheumatology, and yes, we deal with kind of the joints, we deal with the wear and tear and arthritis, and but a lot of our diseases, believe it or not, are very systemic. They can affect any organ in the body. They can affect the heart, the lungs, the skin. And that's kind of the rotation that put everything in context for me, because I could be a specialist, but I also still thought of things very holistically and very kind of the whole patient, got to think about their lungs and their heart while treating their single disease.
Let's talk about arthritis. So many times patients and people coming into my office, or we see them on the street, or even in the studio here, will say, I have arthritis. And it sort of describes anything that bothers them.
Right.
If they're having a problem throwing a ball or bending down or walking, it's always the word arthritis. If I have any weakness, and sometimes it generalizes to various diseases that I take care of. Anyone's numb and weak, well, it's from arthritis, they were told. And a lot of primary care physicians, and again, healthcare providers, will use that term somewhat liberally. So tell us about arthritis. And there are different kinds of arthritis. And people always ask me, is there any way to prevent arthritis? So this is a very complicated question. But tell us a little bit about arthritis and what the viewers really should know about it.
Right. So you raise a lot of good points there. Arthritis is a very vague term, and people do throw it around kind of hodgepodge, and it encompasses over 100 different diagnoses. Arthritis is really an umbrella term. It just means kind of joint pain or irritation, pain in the joints. But there are kind of more nuances to that. There's 100 different types, and really what we do with arthritis is we kind of categorize it into two major types. There's inflammatory arthritis, which is kind of the rheumatologist's bread and butter and kind of the more nuanced and difficult to treat disease because it encompasses things like rheumatoid arthritis, psoriatic arthritis, vasculitis, gout.
Let's break that down a little bit, because we see about psoriasis. I see commercials all the time for psoriasis.
Right.
So what is psoriatic arthritis?
So psoriatic arthritis is an inflammatory arthritis, so one type of arthritis that is deeply linked to psoriasis. So for those who are unaware, psoriasis is a skin condition. It's an autoimmune inflammation of the skin that can be intensely itchy and painful and kind of distressing to patients by how it looks, but it could be deeply linked to arthritis, an inflammatory arthritis of the joints, leading to joint swelling, joint stiffness, pain, and really destruction of the joints.
So that's an inflammatory. So if you had to categorize it, so it sounds like they're the inflammatory arthritis and degenerative.
Yes, so the second type of arthritis is a non-inflammatory arthritis, and that one's kind of, I don't want to say simple, but there's only really one type. It's osteoarthritis. So that's the type of arthritis that if you live long enough, oftentimes you'll get it. I just read a kind of staggering figure because there's the ACR conference that's going on in San Diego right now, and there was an increase in osteoarthritis by 125% since 1990. There's over 600 million people with osteoarthritis in the world.
Wow.
It's a staggering number.
So tell us, what is osteoarthritis?
So osteoarthritis is one of those non-inflammatory arthritides, basically that is due to mechanical wear and tear. We call it non-inflammatory, but there probably is some degree of inflammation in it, but to a much less degree compared to like rheumatoid arthritis or psoriatic arthritis that we briefly mentioned. And osteoarthritis is very painful. It affects primarily our weight-bearing joints, so our knees, our hips, our back, and our highly utilized joints like our hands and our feet. It can be very painful and often disfiguring as well.
Is there, people talk about it, and you said so many people have it.
Right.
So if you have a family member who has it, and you're worried that you're going to get it, is there anything you could do to prevent osteoarthritis or the wear and tear kind of arthritis?
My mentors always told me that if you find the cure to osteoarthritis, you are sitting on a gold mine. So there is no cure necessarily for osteoarthritis, but you bring up the point of prevention. I think that is kind of where a lot of the focus on research is right now. There is absolutely a genetic component, but there is also a lot of lifestyle as well. So obesity is a huge problem in the United States and the world at large. So good weight control, lowering your body mass index, kind of for every pound that you lose, your knees, for example, are feeling 4 less pounds. So it's a multiplicative effect on those knees. So by losing weight, you are preserving your joint function. Not smoking is another kind of thing to do to benefit from osteoarthritis. And then strengthening the muscles. This is why when we treat osteoarthritis, part of the kind of major treatment aspects of osteoarthritis is weight training and strengthening of the muscles kind of surrounding that joint.
So when people go for a replacement, they talk about that all the time.
Right.
What does that mean?
So a replacement comes in various types. We often, as rheumatologists, will refer out to orthopedic surgeries, or will always refer out to orthopedic surgery to do the surgery. But essentially what you're doing is, in most cases, taking this badly damaged joint and often kind of manipulating it in a way so that the damaged portion is no longer present and is often replaced by various different prostheses, different kind of materials that avoid the kind of bone-on-bone grinding that's causing a lot of the pain in osteoarthritis.
What about those injections? People talk about Synvest or hyaluronic acid, things that will get that joint working a little bit, lubricated.
Right.
Do they work?
So that is a contentious point, I think, between rheumatologists, orthopedics, and is often being studied, and that question is being asked a lot. I think the evidence for gel injections and steroid injections is, depends where you look. I think patients will often anecdotally, I'll give a steroid injection or have given a gel injection, and they will feel fantastic. So I think on a kind of personal level, I think it does help. The data has been a little bit more mixed, I would say. in certain patients, I think it really is important really just to kind of look at the patient that's in front of you and think about their characteristics, and is that someone who might benefit from that extra lubrication or a cortisone, steroid injection. So they work, I think, but there is a lot of research that's still going on into that question.
And we're spending a lot of time on osteoarthritis because that's the type that people describe to me all the time.
Sure.
And are concerned about. Is there anything coming up in the future with this? I mean, you said the American College of Rheumatology is having that conference right now.
Yep.
So is anyone coming up with some ideas of how to regrow certain parts of the joint and things like that they can maybe in one day? It's funny, when I grew up, replacements were just becoming a big deal. And now everyone's getting multiple replacements during their lifetime because, thank goodness, people are living longer and doing well, and they want to be more active.
Sure.
The question comes down to, do you think there'll be a time, or there are things that in my lifetime that will change that with regard to needing surgery?
I hope so. Right now, I think there are a lot of things that we're looking into. You'll probably, especially in Europe, I think they're kind of gaining a little bit more traction. PRP, plasma, basically taking plasma and injecting it into the joint, basically to promote kind of regeneration of the cartilage. That's being looked into, as well as stem cell therapies as well. These are all very new therapies. So far, the data is kind of mixed, a little equivocal, whether it works or not, but it is promising. There have been medications that have been looked into. None of them have really panned out so far. Some of them medications that we use for other conditions, but none of them have really panned out so far. So we're hopeful. I think it's something that in our lifetime, I think we will attain, but I think we're not quite there yet.
And we're hoping for it, because that's such a common process.
Yes, absolutely.
So let's go into what the why you became a rheumatologist part. The inflammatory arthritides, or arthritis. Arthritis is just a fancy word for a lot of arthritis. So all these diseases, and they're very scary diseases, rheumatoid arthritis, lupus, you mentioned psoriatic arthritis. First, how would someone know whether to go to a rheumatologist? So if you have joint pain and you go to your internist, your primary care physician, your healthcare provider, how would they know to send you to a rheumatologist? Or do you accept patients who are coming on their own?
Happens all the time. Yeah, we take patients through referrals, and we take patients who self-refer themselves, and not only from their primary care doctor, but because our diseases can be so widely systemic, we will get referrals as well from specialists, from neurologists like yourself, from cardiologists, from pulmonologists, because our diseases are so widely systemic. But if you're seeing your primary care doctor and you have joint pain, you don't necessarily need to see a rheumatologist, but if you're having a hard time controlling your pain, if none of the therapies that you're trying are working, if your primary care doctor is saying, you have a lot of swelling or your blood tests look abnormal, those are all reasons to maybe see a rheumatologist. And then the kind of other tip-off is as well as these systemic features. I think that's what a lot of us rheumatologists look for is, are you rapidly losing weight? Are your joints swelling? Are they getting very stiff? Are you losing hair? Are your hands changing colors? Kind of weird symptoms, getting ulcers or rashes on your skin. These are tip-offs that there might be something that's not just that osteoarthritis, because you don't necessarily need a rheumatologist for osteoarthritis. We're happy to see you, but I think the inflammatory arthritides are the ones where the rheumatologists are the experts.
And I think you mentioned with arthritis, lifestyle change, osteoarthritis, lifestyle changes, wear and tear changes, things like that. With these types of arthritides, these inflammatory processes, you actually have disease-modifying therapies.
Absolutely.
Which is something very different. And as a neuroimmunologist, I'm very much involved with disease-modifying therapies for diseases like MS. So tell us about the disease-modifying therapies and how they've changed the world over the last 20 to 30 years.
And yeah, it's an explosion really in the last 30 years. I think even when I was in training, a couple years ago, 6-7 years ago, we didn't have some of the medications, many of the medications that we have now, and they are completely changing the landscape of rheumatology. And frankly, it's the most exciting part about being a rheumatologist. Just a little bit of history, kind of going back to the 50s, 60s, there was really no effective treatments for a lot of our rheumatic conditions, and it was leading to early death and leading to lots of morbidity and joint destruction, and patients just weren't getting treated appropriately. And then you kind of fast forward a little bit into the the 60s, 70s, we start getting steroids and some better treatments, but still not really very effective in preventing a lot of the damage. But now, as you mentioned, we have these disease-modifying drugs that are targeted. These are medications that are, based off of the science of how these diseases come about, and we, use these molecules, use these medications that target these inflammatory proteins to basically change the landscape, not only improving your symptoms, but also preventing the joints from becoming disfigured, essentially.
So tell me about the kind of medicine. So again, people are interested because a lot of people have different. Let's go back to the TV commercials.
Sure.
You see all kinds of medications for psoriasis.
Yep.
Do they work for the arthritis too?
To some degree, it is a challenging, nuanced question, but the answer is yes. A lot of those molecules that you're seeing, those medications that are being, I feel like it's every other commercial on TV. There's something new there, but they do work both for the skin and for the joints to varying degrees, and trying to find that kind of perfect cocktail essentially for the patient that will treat their symptoms most effectively. There, like we were talking about, there's the skin disease of psoriasis, but then there's the joint aspect of psoriasis. And it doesn't just affect the joints. It can affect your eyes, it can affect the tendons, kind of where the tendon is directly inserting on the bone, called the enthesis. So those different manifestations of psoriatic arthritis respond better to certain treatments better than others. And we're really delving into those now that we have so many options. Is option A better than option B for a given patient? And we're working on figuring out, deciding that beforehand. A lot of times it's trial and error, but right now we're at that point where we have so many medications in our armamentarium to treat these patients.
So tell us about the immune system with this. In any field, we're seeing a lot of the immune system being a crucial portion of it. In my field, things that you'd be shocked. People with stroke, we think about an immunological cause. People with heart attacks have an immunological cause. Alzheimer's disease has an immunological cause. Things that we wouldn't even think about.
Right.
So tell us about the immune system and the joint.
So the immune system, just in general, is a fascinating organ of the body, part of the body, that helps us fight off bacteria and viruses and funguses from invading us. These autoimmune conditions, these like psoriatic arthritis and rheumatoid arthritis, they are autoimmune. So our immune system is trying to defend us from bacteria and defend us from viruses, but in sometimes the immune system goes awry, goes wrong, and starts creating what we call autoantibodies, proteins kind of targeting your own cells, your own joints, your own organs. And because these proteins are there floating around in your bloodstream and kind of targeting your own body, it leads to this intense inflammation. The immune cells that are normally, again, fighting bacteria kind of get directed and targeted towards a given organ or a given joint. And that they basically create all these different proteins, and these proteins recruit more of the immune cells there, and it's kind of this cycle, this vicious cycle where more inflammation begets more damage, and it's kind of just this vicious cycle, and our medications essentially act to block that process.
So tell me, so we talked about joints a lot.
Right.
Now, let's go into tendons. There's almost like an anatomy lesson.
Right, I know.
So there's different parts of the musculoskeletal system, which rheumatology takes care of. And everybody who's played ball, who's over the age of 50, and after they finish, everything hurts.
Right.
So what's happening to them? And there's tendinitis. Maybe give us what I want, if we can, how does a person differentiate what needs to seek medical attention and what doesn't?
So that's a tough question to answer, I would say. I mean, I think what you're getting at as well is, there's joint pain, but then there's also the surrounding tissue. There's the muscles, there's the tendon, there's the enthesis that I mentioned where the tendon is directly inserting on the bone, and all of those can be a point of damage and a point of disease. In simple musculoskeletal injuries like a sprain or a strain, a rotator cuff injury, patients will often say, for example, "Ow, my shoulder hurts." And when we examine them, really what we're getting at is that it's not necessarily the shoulder joint, not what we call the glenohumeral joint. It's not that joint, but rather it's maybe a bursa, a sac that kind of helps lubricate the joint that might be irritated, or a tendon, a rotator cuff. People who've watched baseball or play sports, a rotator cuff injury. It's possible that one of those tendons got irritated or torn. So your question specifically was, when do I seek medical care? I think people are often minimizers, especially on Staten Island. I've realized that they'll wait to the very last minute to go and see a doctor. I would say if you did something that aggravated it, you could take your pain relievers, Tylenol, or an anti-inflammatory topical creams like Voltaren, over-the-counter, diclofenac. And if those sort of modalities are not helping you and it's not going away, or you're unable to mobilize your arm, those are maybe reasons to go to the doctor.
But I'll even go one step further. How about going to the urgent care center after you play? It's always the softball game.
Oh, always.
That's a Staten Island
or
thing.
football.
So playing softball,
Yeah.
and there's some play, and boom, 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 and then you're hurting.
Yeah.
When should someone go to an urgent care center or an emergency room?
Yeah, so musculoskeletal emergencies are one thing that I will often look for if someone's coming into my office. I think things that will prompt someone that they should go to the emergency room or an urgent care: inability to move a joint, at all without pain, kind of pallor, or like the hand going white. Let's say you injured your arm and your whole arm is white, or you can't feel your arm. Those are some reasons. Inability to kind of bear weight on a joint often is a little bit of a concern. Not necessarily always, but I would say if you can't bear weight on your foot, if the ankle is big, red, and swollen, or there's bruising or ecchymoses, or bruising essentially, those are reasons to maybe consider urgent care just to get it checked out.
Tell me about your team. No physician, no healthcare provider ever is alone.
No.
There are teams. There are actually specialty centers.
Mm-hmm.
You think about places like the Hospital of Special Surgery, where various joint replacements. It's sort of there's a whole group that works together, and we're trying to build a lot of those programs out here.
Yeah, right.
So tell me about how is a team and your team works together to help people who are having problems with their joints.
Right, and I think that is a very nice aspect about rheumatology. I mean, medicine just by itself is a team sport. I mean, it takes a village, it takes a hospital really to take care of these patients. But I think that it's very true for rheumatologists because our diseases can be so widely systemic, so widely effective of different organs. We have to work closely with our neurologist colleagues and our cardiologist colleagues and form those relationships so there's an open communication with these providers, so that I'm taking care of their lupus, but for example, their lupus could be affecting their heart. So I have a good relationship with Dr. Rheumatology, for example, so that we can kind of treat that patient and make on-the-fly decisions kind of rapidly and treat them most effectively. Right now, my team, we have an office on Clove Road as well as Amboy, and we have medical assistants, secretarial staff, office managers, and then these offices often have other providers in them. So I work in the Clove office with a nephrologist. Rheumatologists and nephrologists are really good friends.
Nephrologist being
a kidney doctor, as well as neurologists, brain doctors. So we work with these other specialties essentially to make sure that we're treating these patients very effectively.
Sounds reasonable, but I think I was almost looking for a different part. I was looking more for the physical therapy part.
Okay.
So tell me about the relationship of how physical therapists and rheumatologists get together in order to get people better. And you mentioned strengthening muscles.
Sure.
But do you have specific orders or regimens that you want your physical therapist to go through? I think I've seen this a little much in my practice.
Right.
I take care of patients who have neck and back pain, as you do. And sometimes the goal is to do everything in the world. And basically, people who couldn't do sit-ups before they had the injury, now are trying to do more sit-ups and trying to do different things. And they overdo it even at the physical therapist's office, even right in front of me.
Right.
So tell me about the way you guide and deal with the physical therapist.
The physical therapists on Staten Island that I've worked with are exceptional. I have some good colleagues and friends at JAG 1, and I will work with them to basically kind of fine-tune the regimen for the patient. It does depend on kind of what disease, so it's kind of a broad question, but at large, really it is kind of strengthening, kind of we call them isometric, exercises, basically things that are not putting too much weight on the joint per se, and really more strengthening the muscle around that. So I use the knee with osteoarthritis, for example, where you have your calf muscles and your thigh muscles, and really there's kind of bone rubbing against bone in osteoarthritis, and that grinding is what's causing the majority of the pain. So if you're doing certain exercises, and we'll work with the rheumatologist with the physical therapist rather, to kind of fine-tune exercises that patient can tolerate. Usually it's things that are not too weight-based, so we're not having them run the New York City Marathon. We're not having them kind of do deadlifts and squats. We're having them kind of, bear their body weight first, maybe add a couple of small weights to that. We do some squats, some lunges. It really depends on what they are capable of, and listening to both, working with the patient, listening to the physical therapist, what they're capable of. And then there are other modalities, we call them, so things like TENS units for back pain, massage therapy, aerobic exercise, water exercises, are all beneficial.
So what if someone tells you, comes in with osteoarthritis, and says they want to run the marathon? We have to be very encouraging to our patients,
Right.
From a number of the point of view. Well, what do you say? First, you cringe inside, and as a rheumatologist, what are your thoughts?
It kind of depends. Where are we in the time frame? So the New York City Marathon just happened. So
Right.
do we have a year of training? Because then maybe we're talking. I mean, I think it really depends on the patient. Were you running marathons before you developed this osteoarthritis? So is that something you were ever capable of? But I think I like to listen to my patients and see what their goals are, because I think that if their goal is to run that marathon, and that's something that is a real hope and dream of theirs, I think it is always reasonable. Will we get there? No, maybe, who knows? But I think that creating the expectation and creating that treatment plan and creating that relationship with the patient is the most important aspect. And then trying to create realistic steps to get you there. So are you someone who might better benefit from a steroid injection or a gel injection? Are you someone who probably should have that knee replacement first, get some physical therapy, get some healing, and then run that marathon? Because there are people who do that. So it kind of depends on your functional status before, and then how much time we have.
I think the relationship answer is the one that's so crucial,
Right.
to see what patients are doing. So you mentioned that the infusion suite might be starting, that you're going to go, or actually continuing. I want to take the fear out of some of these things. There's some bad diseases.
Right.
Disease like systemic lupus is a bad disease. You say it affects the heart, the joints, and there are medicines available for it. Some of the things we see on television are pills. Some of them are shots or injections.
Right.
Tell us about the infusion therapies that are available.
Right. So thankfully, lupus was one of those, we call it an orphan disease. It didn't have many effective treatments. It had trouble kind of getting approvals for these medications for a long time by the FDA. Now we fortunately do have treatments. Again, some of them oral, some of them injections, but now we are thankfully having more infusion medications. And what we mean by that, again, is kind of through an IV, through an intravenous route, often in a specialized center like a hospital or an infusion suite. And these are medications, again, that we didn't have until very recently, that are targeted to the mechanisms, the pathophysiology, the origins of lupus, the molecules that are causing lupus. And these are very targeted therapies, so they are very specialized. And these are medications that I think people are very fearful of. I think I hear the concern there by a lot of my patients, today even. And these are medications that do have potential side effects. And really, these are very well-studied medications. These are medications that we'll give in a given cocktail with medications to decrease those risks of side effects with steroids and antihistamines or Benadryl, Tylenol, these different medications to basically diminish or decrease those risks of
We are finishing
side
up.
effects.
We only got like 10 seconds
Okay.
left, but I want to say thank you.
Sure.
Those are game-changing.
Absolutely.
So thank you.
Yep.
What a pleasure to spend this half hour with you. Thank you to everyone and for watching us. And think about your joints, and they're very, very important, as we all know. Have a great night.
Thank you.